Hi everyone, I'm Ed Highland. This is the Big Ideas Theater at AARC. And I'm joined now by Kimberly Firestone, who's with Akron Children's Hospital. Kimberly, thank you so much for coming by.
Well, thank you for having me.
We're going to talk a little bit about the practical bedside management of neonates on non-invasive ventilation. Could you give us the big picture first?
So the big picture is that non-invasive ventilation is such an important aspect now of handling the premature infant or any baby that is having respiratory distress. Respiratory issues are such a big part of the neonatal world, and non-invasive ventilation was actually very prevalent back in the 70s, and then we went to invasive ventilation, and we're actually coming back around to non-invasive ventilation techniques again.
And obviously the respiratory therapist playing a key role in all of this.
So the respiratory therapist's role in this is so very important. I really don't feel that bedside management could happen without the respiratory therapist. They're the ones that know the techniques. They're the ones that know the proper sizing of masks. They're the ones who understand when a patient is not tolerating it as well, what are some of the other options for them. And so one of the courses actually we teach is how do you recognize that the neonate needs a new technique, possibly needs a new modality, possibly needs a new interface system. And a lot of research has been done lately on this, and you can find a lot about it now when you do a lit search.
Forgive me for being a layperson and asking this question, but it almost seems a lot has to do with, you almost have to have an intuition in some ways. I mean, you have the equipment, you have the technology, and you have the knowledge, but so much of this is very dependent on, as you say, recognizing what the patient really can't say to you, what can't express to you at this age.
Correct, and that's what's so wonderful about the neonatal population is you need to know their cues. An adult patient can give you cues, but many times has learned how to compensate over the years. And a neonate gives you those fresh, non-compensated signs that if you learn how to pick up on them, you will know then how to treat it.
Give us some thoughts, if you would, on the different types, the different modalities, some of the different techniques.
Sure. So some of the different modalities are bubble CPAP, which when I said that we went back into the 70s, that was what we used in the 70s, and it has actually made, it has come back in full circle. We can use that because it is a good modality, but it's also an inexpensive modality. We have ventilators that we can use, and we can either deliver constant positive airway pressure, the CPAP, or we can deliver non-invasive ventilation. And there are many vents that are available, and you can choose from them, obviously what your hospital provides, but you can choose from that what you think would be the best modality for your patient.
Talk a little bit about the team effort. In other words, being able to do, because you're not alone in this effort.
So the team effort is so very important with the respiratory therapy role. One of the things that we do in our institution is we have respiratory rounds every morning, and they start at 8 o'clock and they last about 30 minutes. And what we discuss there is every patient that's in the NICU, that what modality are they on, is it the appropriate, can we change things? And that team consists of the nurse practitioner, the bedside nurse, the respiratory therapist, and the physician, possibly the resident group. All of those team members are important in deciding, are we doing the correct thing for this patient? But it's the respiratory therapist that actually returns back to the bedside after rounds to implement some of the modalities that we have talked about on rounds.
Can you give some thoughts on how things have changed and progressed? You mentioned that in some ways we're looking back to previous techniques, to the 70s in some instances, but is it getting better? Is it getting easier to use some of the technology that's available?
Oh, I think it's getting so much easier. There are so many signs and indicators that we have now to let us know how your patient is doing. Pulse oximetry, CO2 monitoring. There is obviously blood gases, we've had those in the past, but you can, and then the continuous monitoring from your cardiac situation. So we have a lot of feedback now that we didn't have prior. We also have modalities that give us more information. In the past, I didn't know if a CPAP was disconnected, a bubble CPAP. Now I will know. We can put alarms on those. So we have a lot of increased technology for us. The ventilators today are phenomenal. They give you so much information that wasn't available to us in the past.
I would think in your position, and also the fact that Akron Children's Hospital is pretty well known, that you'd get a lot of calls. A lot of people would be looking for you to share your experience, as well as export some of the thoughts about the care that you've been able to do over the past few years, but also what you might be able to do in the future.
Right, we do. We receive a lot of calls. We also have people come sometimes to our unit and do an observation.
And that's encouraged? I mean, you're okay?
It's very encouraged. The only thing that we ask is you signed a HIPAA form before you come in. But we actually, to be honest with you, I enjoy when people come to do an observation with us, because I honestly learn as much as they do. I learn as much from them. Another thing that we do is a simulation program, and we have a simulation center where we will simulate extubating a patient, putting them on non-invasive ventilation, trying all the various techniques that are available to us, pressure redistribution devices, the interface systems, and so you get to use them on a mannequin and feel comfortable with it before then you are using it with a real patient.
So you have a simulator for extubation there?
So we just use we have a high fidelity simulator that we use. It's used for a lot of different things, but we will use extubation with that.
Well, you'll just need to stop by Akron Children's Hospital and ask for Kimberly Firestone. Kimberly, thank you so much for coming by and chatting with us here in the Big Ideas Theater.
Thank you for having me.
And this is the Big Ideas Theater. I'm Ed Highland. Thanks for joining us.